Family Medicine and Primary Healthcare Micromodules 2016 by Professor Carmen Wong. Common Genital Urinary Conditions by Professor Carmen Wong. Learning Outcomes. At the end of this module, we expect that you will know how to diagnose and manage urinary tract infections in men and women. That you'll also be able to manage conditions such as vulvovaginitis, non-specific urethritis, and also benign prostate hypertrophy, and knowing how to use PSA in your management plan. So take a little moment to have a look at this flow chart. You may wish to pause the video so you can have an in-depth look. Essentially, you need to differentiate, well, is this a urinary symptom or is this a vaginal itch, discharge, or complaint? With regards to urinary symptoms, then you'll be looking for symptoms and signs of a UTI, things such as dysuria, urgency, frequency, polyuria, suprapubic tenderness, fever, flank or back pain. So if they're limited, you may, such as one or two symptoms, you may see clinicians use urine dipsticks to help with the diagnoses and then offer antibiotic treatment. If there are multiple symptoms and the patient is suffering from fever and back pain, then you may think that it may be a complicated UTI requiring different treatment. If not, then you should be giving a 3-day prescription of an appropriate antibiotic, and we'll talk about appropriate antibiotic in our next slide. So what would be an appropriate antibiotic? So looking at antibiotic resistance rates of uropathogens in Hong Kong, you can see that actually E. coli, which is the most common pathogen, least resistant to augmentin and nitrofurantoin. So actually those would be the first line treatments for UTI. There's actually quite a high resistance in Hong Kong for this, and so this isn't advocated. Clotrimazole, which may be seen in some of the guidelines you see from the UK. So the signs and symptoms of an upper urinary tract infection consists of loin pain, flank tenderness, fever, rigors, and other manifestation of systemic inflammatory response. You may think about then the condition of the patient to see whether or not they need to be admitted to hospital. So these may be things like fever, confusion, dehydration. If there's no systemic symptoms, then you can consider treatment with ciprofloxacin for at least 7 days. Also note that the urine should be taken for culture before empirical treatment so that we'll know if we need to change the antibiotic. You would expect the response to treatment in about 24 to 48 hours after the antibiotic. Now, if the patient is dehydrated, is vomiting, unable to take oral antibiotics, again, they may need admission to hospital. So, if we're thinking about vaginal causes, so the vulvovaginitis, there's actually 3 most common causes, which is BV, candidiasis, and trichomonas. So you'll find that with BV, you may have sort of moderate to profuse amounts of discharge. You may have malodor or yellow discharge. Candidiasis, you'll have this thick, curdy discharge and inflammation of the vulvovagina, some excoriation, and usually pretty itchy. Trichomonas may be minimal symptoms, or they may have yellow discharge. Now, sometimes just looking at those features actually has very low sensitivity and specificity to the diagnosis. So actually a vaginal swab specimen could be done. And actually now what's advocated that actually you don't need a speculum, but you just need to swab inside the vagina to know which is the pathogen, and then the treatment may be metronidazole or an antifungal in various doses depending on the pathogen. Other causes can include herpes simplex virus, atrophic vaginitis, contact dermatitis, lichen sclerosis, mucopurulent cervicitis. And this could be from chlamydia or gonorrhea. Urinary symptoms in men, slightly more complicated because actually men don't tend to have urinary tract infections. So they may present with very similar symptoms of dysuria, urgency, frequency, polyuria, suprapubic tenderness, fever, flank or back pain. Differential diagnosis could include prostatitis, chlamydia, epididymitis. So in all men with symptoms of UTI, a urine sample should be taken for culture. Now, if there's any history of fever or back pain, you consider the possibility of an upper UTI, and a 2-week course of ciprofloxacin would be needed. And again, you need to take a urine culture before you give the antibiotic. If there is recurrent UTI, then the patient will need further investigations. And if not, then you may just proceed with the antibiotic and see how they respond. So non-specific urethritis in men is commonly caused by gonorrhea or chlamydia. The clinical presentation, it could be asymptomatic, but then you wouldn't know about it. So the patients that present usually present with some sort of stinging or burning during urination. They may be itching or tingling or burning or irritation that they feel inside the penis. And some patients may have a discharge which might be milky or pus-like from the urethral orifice. So this is a diagram to show that in non-specific urethritis, you should think about other STDs apart from chlamydia and gonorrhea that may be causing, that they're a higher risk of getting because of unprotected sex. So if they do have a discharge, then you treat empirically for gonorrhea and chlamydia, and you ask them to do a syphilis and HIV test as well, regardless. And in all these cases, you will need to educate the patient for behavioral change, thinking about barrier methods such as condoms to prevent STDs and further infection with their partner. And it may be that you have to do contact tracing if the partner also has symptoms, or if the symptoms, or if the patient has positive results. Now, if the patient presents with an ulcer, then you would have to treat for and think about genital ulcers, and we'll talk about that in a little bit. So treating empirically for chlamydia and gonorrhea, what are our options? So you'll need ceftriaxone 250 milligrams IM plus azithromycin 1 gram orally in 1 dose. And usually we want to treat patients empirically before any results, just in case they don't return to the clinic. Other alternatives, you can use cefacim instead of ceftriaxone and doxycycline instead of azithromycin, although those the doses are longer. So what if there is genital ulcer or sore? So you need to take a sexual history and physical examination, and you need to ask them to do a syphilis or a HIV test as well. So if it's positive for syphilis, then they will have to syphilis treatment, and if not, then you may think of other diagnoses such as herpes as well. Again, you'll need to educate for behavioral change and promote or even provide condoms, and this is usually done in the GU clinics as routine. So with gonorrhea, you're likely to get a yellowish discharge, discolored discharge. It's caused by gram-negative diplococci, Neisseria gonorrhea, and a confirmatory test is PCR or NAT on first void urine. Treatment will be ceftriaxone 250 milligrams, a single dose IM, although there are other alternative therapy as well. Chlamydia is caused by Chlamydia trachomatis, It's the prevalence rate in sexual active population is 5 to 10%, although it can be asymptomatic. Treatment is with azithromycin 1 gram stat dose or doxycycline 100 milligrams BD for 7 days. This is, and if they're allergic to those, having a course of erythromycin. And this is also the same treatment for non-gonococcal urethritis as well. So syphilis, caused by Treponema pallidum. So this is where you have a canker or ulcer, a penile ulcer. Treatment for this would be the same for primary, secondary, or early latent syphilis, which includes porcaine penicillin IM for 10 days, doxycycline 100 milligrams BD, tetracycline 500 milligrams QDS, or erythromycin 500 milligrams QDS, on all of those for 2 weeks. So prevention is key. You need to educate and counsel patients on methods to avoid sexually transmitted diseases, including abstinence or reduction in the number of sexual partners, use of male or female condoms, cervical diaphragms, and pre- and post-exposure prophylaxis for HIV and other sexually transmitted disease. Next, to lower urinary tract symptoms, such as those of benign prostate hypertrophy, BPH. So you may have some irritative symptoms. These include frequency, urgency, nocturia, or urgency incontinence, or some obstructive or voiding symptoms such as hesitancy, incomplete voiding, poor or intermittent stream, straining, post-micturition, dribbling. And most importantly, in these conditions is to think about patients' quality of life. So moderate to severe LUTS symptoms are very common, and they present in about half of men by the time that men reach age 70 to 79. Also remember in your history taking to ask history of hematuria, UTI, renal insufficiency, any stones, strictures, or other urological disease. This is an example of the scoring that's used in the International Prostate Symptom Score. And as you can see, you're rating the symptoms in the past month on a 6-point scale. And also to note is the quality of life, which is also very important to how you manage the patient. So assessment of LUTS. So physical examination, palpate the abdomen, and what you're trying to look for is the suprapubic area for bladder distension and pain. And how about a PSA? Well, elevated prostate-specific antigen, PSA, can actually occur in prostate cancer, but also in benign prostatic hyperplasia, or benign prostate hypertrophy, and prostatitis. So screening for prostate cancer. So routine screening is not really recommended without actually having done a digital rectal examination. And we should be doing that for all patients over the age of 50. So one of the troubles about PSA is that people are trying to gauge, well, what is a normal level for PSA? So although on the laboratory forms it will say that PSA of less than 4 is normal, you will find that actually studies have shown that about 15% may have PSA less than 4, but are still diagnosed with CA prostate. And in about 15% of those were high-grade carcinomas as well. Now, about a quarter to a third of patients have PSAs above 4, but less than 10. And then they underwent prostate biopsy, and they were also diagnosed with CA prostate as well. So it's really difficult to establish at what level you do and you don't refer to urology. We know that the PSA tends to increase with age, and there's no definite value for PSA given the evidence that was shown. So the resulting advice really is to do a baseline PSA and then to serially monitor along with the clinical picture so that you can make an assessment of when to refer. So what if the screening test results show an elevated PSA? Well, you need to find the underlying cause. So you may need to repeat the PSA and also the DRE, the digital rectal examination, regularly to look for any changes. You should do a urine test and look for UTI. And you may refer to the urologist for a transrectal ultrasound, a biopsy, or cystoscopy. So management of BPH. So drugs provide symptomatic benefit. Men with relatively high symptom scores might not be particularly bothered by their urinary symptoms. So that's why it's important to ask about the effects on their daily activities and also their quality of life. So your treatment options will be alpha blockers such as prazosin, terazosin, doxazosin. So you might want to start at the lowest dose and slowly titrate up. Common side effects will include postural hypertension, dizziness, syncope, leg edema, tiredness, weakness, lethargy, tremor, or impotence. The other therapy, the 5-alpha reductase inhibitor, may be more beneficial for those with a large prostate or with severe symptoms. So this includes finasteride or dutasteride. Common side effects include impotence, low libido, swelling of hands and feet, dizziness, and weakness. Along with management and also history is to look out for any drugs that might be making symptoms worse. This could be antihistamines, muscle relaxants, opioids, tricyclic antidepressants, antispasmodics, and drugs that work on the sympathetic system. With regards to their diet, it will be particularly useful to limit their fluid intake, particularly in the evening, and to avoid excessive alcohol or highly seasoned or irritative foods. Increasing physical exercise seems to help, as does bladder retraining, so increasing the time between voids to about 3 hours. There's also suggestions for double voiding and making sure that they completely empty their bladder once they go. Referral to surgery is when your treatment options conservatively are limited and you're failing to control symptoms. There are risks of surgery, more specifically of impotence and urinary incontinence, but you may want to consider referral if there is renal insufficiency due to a BPH or recurrent UTIs, bladder stones, or gross hematuria, or there's progressive bladder dysfunction. So some practical tips. Patients that present with symptoms may have a mixed bag of symptoms. So it's really important that you ask precise questions as to delineate whether it's what kind of cause. For example, is it a vaginitis or is it urinary symptoms for females, or whether it's a LUTS, BPH symptoms versus UTI. You will also need to take care when you're communicating sensitive kind of issues, and particularly in history taking, where you may first need to communicate patients' confidentiality, and then when you're transitioning between asking perhaps urinary symptoms to taking a sexual history, to notify patients to why you are doing so, because they may not know that you're trying to rule out a sexual transmitted infection, or they may be sensitive to you asking those questions. So in our further training, we're going to be looking at some exercises, and we'll be discussing some of the questions that you may have with regards to management. And in clinic sessions, you will see UTIs and BPH because they're very common, and we'll be expecting you to be able to take a history, to examine, to formulate diagnoses and a management plan for these.